Greetings. Let me review colon anatomy and pathology relevant for endoscopy nurses and technicians. One of the commonest procedures that we perform is screening and surveillance colonoscopy. In this, the goal is to reach the cecum in over 95% of the cases. And then as you come back, I would like to share with you the different sections of the colon. Right now, we are in the cecum, entered into the IC valve into the terminal ileum, come back into the ascending colon, turn around under the liver, hepatic flexure, go across transversely, the transverse colon, and turn around the spleen, under the spleen, the splenic flexure, come down into the descending colon, and then through the S-shaped sigmoid colon, and finally into the rectum, lower rectum, and then retroflex to check the dentate line and looking for hemorrhoids, and finally straighten the scope and come out. Initially, we were told that a withdrawal time of 6 minutes is good enough, but now data shows longer withdrawal time, including as long as 10 minutes, makes a lot of difference in finding polyps. So say, for example, you see a polyp, you need to figure out the character of the polyp. We all know the size and the location of the polyp, but the type of the polyp. So I'm going to go through the classification of the polyp, starting on the left side. Imagine this. You have a mushroom with a stalk, and as you go from the left to the right, the stalk becomes shorter and no stalk to the point of becoming flatter and depressed. So on the left, you have pedunculated polyp, 1P, a shorter stalk, subpedunculated polyp, 1SP, no stalk, that is sessile, when the height is more than the width of the polyp. And when it is flat, the height is less than the size of a biopsy forceps, and it's going across. Width is more than the height, then it is flat, elevated. Flat, almost 2B, that is, you can barely see it elevated above the lining. And then if it is depressed, 2C. And finally, if there is some depression and some elevation, it is called a mixed type. So you learned about the Paris classification of polyps. You should be able to describe it when you see a polyp. Let me show you some examples. Here is a pedunculated polyp with a pedicle and a sessile polyp, a flat elevated 2A lesion, and it could be lobulated or granular or non-granular when it is completely smooth. And finally, a 2B lesion, you are barely able to see. Look at the blood vessel, and one blood vessel in the middle disappears under the polyp. This turned out to be sessile serrated adenoma. So that is 2B lesion. And here there is some depression, some elevation. This is a mixed type of polyp, 2C, 2A lesion. So when you remove a polyp or when you see a lesion, how do you know whether it is benign or cancer? The pathologist will tell you whether the lesion is benign or cancer, but most of the endoscopists are able to define it by doing NBI and looking at the surface pit pattern and surface vascular pattern. But let me share with you what the pathologist will tell us. Before we go there, we want to look at the colon wall anatomy. So you have the lumen. Adjacent to the lumen, you have the mucosa. And below the mucosa, you have the submucosa with blood vessels and connective tissue that lies on a muscle layer, the muscularis propria, and the outer serosa. And then outside you have the blood vessels and the lymph nodes. So let us focus on the mucosa next. Mucosa has three components: epithelium, lamina propria, and the mucosa is separated from the submucosa by a thin layer of muscle that is called muscularis mucosa. So when you have a polyp or a neoplastic tissue that is limited to the epithelium, it is called M1 lesion. This could be a tubular adenoma with or without low or high grade dysplasia. This is not invasive at all. It is staying in the epithelium. When it goes from the epithelium into the lamina propria, then this is what we call intramucosal cancer, as long as it is limited to the muscularis mucosa. Intraepithelial neoplasia, low-grade dysplasia, high-grade dysplasia, intramucosal cancer can be removed using endoscopic mucosal resection. If you remove that, you lead to curative resection. But sometimes the lesion goes from the mucosa, penetrating the muscularis mucosa into the submucosa. If it is in the upper one-third, it is SM1, going into the middle one-third SM2, and lower one-third is SM3. SM1 lesions can also be removed, and this is best done with endoscopic submucosal dissection, because the lymphatics in the upper one-third of the submucosa in the colon are very sparse. So you can lead to curative resection. But if it goes to SM2 or SM3, there is going to be lymphatic spread. So these patients will require surgery to clear the lymph nodes. So when the lesion goes to the muscle, touches the muscle or invades the muscle, it is called T2. So now we have understood about uh, the different stages of polyps as they go from the epithelium to the muscle and out, T1 and T2 lesions. So let us look at some clinical scenarios. It's not uncommon for us to do colonoscopy when somebody presents with bloody diarrhea. When you have bloody diarrhea, you have to think about colitis. So here is a colon, and on the right side you see a nice colon wall with no inflammation. When there is inflammation of the mucosa, you call it colitis, and we will talk about ulcerative colitis here. And you can have colitis from infections also. But let us talk about ulcerative colitis. Ulcerative colitis typically starts in the rectum, and that is known as proctitis. And then when it spreads up into the left colon uh, in a contiguous manner and in a symmetrical manner, and reaches up to the splenic flexure but doesn't go beyond, it is known as left-sided colitis. If it goes proximal to the splenic flexure, then it is known as extensive or pancolitis. So ulcerative colitis, proctitis, left-sided colitis, pancolitis. Ulcerative colitis, inflammation is continuous inflammation, contiguous, without leaving any gaps, and it is symmetrical inflammation in a circumferential manner. The reason I want you to keep in mind is when you compare ulcerative colitis with Crohn's disease, you will see a lot of differences. Ulcerative colitis is a mucosal inflammation. In Crohn's colitis, it is transmural inflammation. And unlike ulcerative colitis, Crohn's colitis has areas that it skips, and then involves other segments. When you see skip areas, you have to think about Crohn's disease. And we also may look and see in a particular segment, it may involve one wall and leave the other wall. That is asymmetrical involvement. So transmural inflammation, skip areas, asymmetric involvement, these are all features of Crohn's disease. In ulcerative colitis, it is a mucosal inflammation, continuous inflammation, symmetrical involvement without transmural inflammation. So let us understand about Crohn's disease a little bit better. So here is a normal wall on the right side, focus on the section, and there will be transmural inflammation from the mucosa, submucosa, muscularis propria. And then as the disease goes on, you may develop fissures, and the fissures may become deep into fistulas, and the fistulas may end up with abscesses. And this is typically a problem around the perianal area. Perianal abscesses are a feature of Crohn's disease. So we've learned about ulcerative colitis and Crohn's disease. So when you do a scope, you want to figure out, is there ulcerative colitis or not? Here is a normal, healthy colon. You identify by the sharp haustral folds, nice shiny mucosa, and an excellent visible vascular pattern. When you see a patient with ulcerative colitis, here it is mild colitis, you notice erythema, and you don't see the vessels, absent or decreased vascular pattern. When it becomes severe, moderate colitis, you will see those breaks, erosions. And it goes further, you will see ulcerations and bleeding in severe colitis. So we learned about endoscopic features of mild, moderate, severe ulcerative colitis. How about Crohn's colitis? We learned about what is normal colon. In Crohn's colitis, you will have fissuring ulcers, deep ulcers, asymmetric involvement, and skip areas. And Crohn's may have colitis, and there may be rectal sparing, and it's not uncommon to have strictures and fistulas. Another reason why we do endoscopy is if somebody comes in with bleeding per rectum. One of the most common causes of bleeding is diverticulosis. Here you see diverticulosis, and you notice bleeding from diverticulosis. Then you have to decide, are you going to use a clip or a cautery? Let us find out when do you use clip and when do you use cautery. Here is a diverticulum. You have a blood vessel that is bleeding. You want to find out if the bleeding source is in the dome of the diverticulum. And if that is the case, the treatment should be clip. You don't want to use cautery because you can perforate. On the other hand, the bleeding source is at the neck of the diverticulum, and in this case you can use a clip or cautery. So that is about diverticular bleeding. Next, talk about post-polypectomy bleeding. In this case, you can use any one of these, clip, epi injection, hemospray, cautery, whatever. They all work depending upon the location. If you have telangiectasia, you use cautery, typically with APC. Best is to use APC after injecting a little bit of saline with a little bit of AP so that you create a submucosal cushion and less risk for perforation. If you have a bleeding polyp, snare resection. If you have cancer, hemospray. And finally, when you see hemorrhoids, you should consider band ligation. On the other hand, if you have severe colitis with bleeding, then you should manage it medically. I hope this is helpful. Thank you.